Alrighty, welcome back, everybody. Had a nice long little lunch this afternoon. We've got a couple more lectures coming up, two very exciting ones. So first, we're going to hear Dr. Swati Patel talk about colorectal cancer screening. She is the director of hereditary GI cancer here on campus, and we all are obsessed with her and are very excited to hear her talk.
Good afternoon. So, normally people typically say, "Oh, thank you for that kind introduction." That was just a bizarre introduction. But it's really, really exciting to be here and lovely to see you all. This is one of the invitations every 2 years that I'm super excited to say yes to. I got the post-lunch spot, so I'll do my best to keep everyone interested and engaged, but please, I will not be offended if you nod off, because after a great lunch, it's completely expected. So these are my disclosures. They have nothing to do with what we're going to talk about today. So as those of you who have scoped with me know, I could talk about colon cancer screening and prevention all day, multi-days. But in the limited time that we have this afternoon, I'd really like to kind of give you the hottest updates in screening and in surveillance, and stuff that certainly your patients probably have questions about, but maybe even have been kind of catching your attention as it's shown in the press or in the media, questions that you might have for yourself or your family members. So hopefully it's a practically useful talk, no matter how near or far you are from our GI patients. So if we start with kind of some of the most interesting updates in screening, well, it's really no news to this audience that colon cancer is a leading cause of cancer in this country and a kind of leading cause of cancer-related death. There are multiple screening options that we have, and we kind of put them into these three buckets, right? And so most folks in the room and online are most familiar with colonoscopy. We're at an endoscopy conference after all. But that's in the bucket of tests that we consider structural tests, right? So tests that can visualize the entire colon for the most part, also include CT colonography, tests that we don't do as much here in the United States, like capsule colonoscopy, so similar to small bowel capsule, but specifically designed for colon visualization. And then antiquated tests that we don't really use that much anymore for screening, like barium enema. Don't wish that exam upon anyone that I know. And then flexible sigmoidoscopy, which we use for other reasons, but not so much for screening. On the other hand, stool-based tests are tests that are essentially designed to detect the products of cancer as they're shed into the stool. And so for a long time, historically, that was microscopic blood. So the old school FOBT test where you had to do 3 tests in a row, you had to restrict your diet in terms of not having any red meat because that could cause a false positive, to our newer iteration that we use, the fecal immunochemical testing, which is a lot easier. It's a single-use test on a single sample and is much more easy to use without restrictions for our patients. And then, of course, this FIT fecal DNA. So it's a combination of FIT and stool DNA markers. And most have probably seen the marketing on NPR, on television for the kind of multi-targeted stool DNA test. And then, for a while, we've kind of known that there's been blood tests, but have not really paid much attention to them and haven't really been a part of the screening conversation up until actually just a few weeks ago. So that's the most kind of exciting change in screening that we'll talk about a little bit today. But no matter what test we're thinking about, right, we have to really understand what these tests are designed to do. So we know that in colon cancer, the vast majority of colon cancers develop from small polyps that grow over time into early stage cancers that then can progress to later stage cancers. And this process takes a very, very long time, 8 to 15 years sometimes. And the tests that we have can kind of detect disease along this spectrum. The structural tests, right, like colonoscopy, can find even tiny, potentially precancerous polyps. And then, of course, can also find cancers, either at early stages before a patient has any symptoms, and ideally that's the stage we want to find it, or unfortunately, sometimes even at later stages. But we can actually use colonoscopy to detect disease along this entire spectrum. So it's not just a cancer screening test, but it's also a cancer prevention test. On the other hand, the stool-based tests are really designed as a cancer screening test, right? They are designed to pick up what a tumor might shed into the stool and try to find that cancer before a patient has symptoms, before a patient actually presents for care. And the goal is to find that cancer at an early stage. Up until recently, blood tests really weren't in the discussion because they were only finding cancers at very late stages where really, the cat's out of the bag and we're not actually helping a patient in terms of increasing their survival and improving their quality of life and not having to deal with things like surgery, chemotherapy, radiation. Regardless of what test we're talking about, colonoscopy is a key component to the screening process, right? Because if any one of these tests is abnormal, it requires a follow-up colonoscopy to identify why it's abnormal, to do biopsies, and set the patient along to the next step. So none of these tests, as exciting as they are to talk about, really are effective without a high-quality follow-up colonoscopy. So when we think about the question that commonly our patients ask us, well, what's the best one? In fact, there actually aren't studies that do head-to-head comparisons between all these options. And so because of that, all of our major professional societies, the United States Preventive Services Task Force, the National Comprehensive Cancer Network, the American Cancer Society, our GI societies, which are represented by the Multi-Society Task Force, really recommend that we can offer our patients a menu of options. But all of them are fairly consistent in recommending screening starting at the age of 45, which, as many of you know, has been a change over the last few years. So when we think about the question of what the best test is out of all of these tests in these three different buckets, the answer is a little bit different depending on how you think about the question, right? If it's a test for you, or for me, and especially because we are biased as GI providers, we might say, gosh, this is a no-brainer. Why are we spending 40 minutes talking about this? Colonoscopy is the best test for me. It's the best test for you. But it's a different question when we're thinking about, well, what's the best test for our society? And when we think about colon cancer in our country being a top cancer and a top cancer-related death, that really starts to beg the question of, well, even if it's the best test for any one individual, how far is it actually pushing the needle to helping our society in this public health issue? So when we think about a screening test, and this is really relevant to not just cancer screening, but other things, cardiovascular disease, whatever it is, a successful screening program requires several components. So the disease itself, theoretically, should be something that is a substantial public health issue, okay? And we've already seen that that certainly is the case for colon cancer. We have a lot of work to do to kind of bring that incidence and mortality rate down. And put another way, really when we think about colon cancer, 5 out of 100 people, right? 5% lifetime risk. 5 out of 100 people will develop colon cancer over their lifetimes if they don't get any screening. The other part that's really useful for a successful screening program is if the issue that we're talking about, we can actually find it in kind of early phases of the disease. And if we do find it, we can do something about it such that it improves people's lives. It saves them from dying from that cancer. It saves them from really high cost, high burden interventions like chemotherapy, radiation, improves their long-term outcomes. And so what do we know about colon cancer in that respect? Well, as I mentioned, we all kind of are familiar with the fact that colon cancer takes a very, very long time to develop from small polyps that over time grow. We know that when diagnosed in these later stages, stage 3, stage 4 disease, it's a substantial burden on our patients, our friends, our family members who have had to deal with this disease. And that includes not just the side effects and the burden of going through treatment, but also the cost associated with treatment and the opportunity cost of not being able to be a productive member and a contributing member to their families and society. And even if an individual survives cancer, they have long-term survivorship issues in terms of financial toxicity as well as side effects. Unfortunately, those diagnosed at later stages have a very poor survival rate. only about 13% of individuals with stage 4 disease make it past 5 years. The good news is that if we find it at earlier stages, stage 1, stage 2 disease, and certainly in our world, precancerous polyps, there's nearly 100% survival. And we save patients all of this morbidity and mortality if we can find it at early stages. So we have a disease that's a huge public health issue. If we find it early, we can actually improve lives. So we actually need a test that can do that effectively, right? So how do we define a test that has optimal test characteristics? We think about this concept of sensitivity, right? So if you have a certain number of individuals, 20 individuals who have colon cancer, how good is the test at picking up colon cancer in all those people? Well, colonoscopy, as we all know, is very, very, very good. It's a sensitivity of over 99.5%, okay? What about some of these other tests that we talked about? Well, the stool-based tests, fecal immunochemical testing, so detecting microscopic blood that's shed into the stool, will pick up about 8 out of 10 individuals with known cancer. So it's not perfect. If we add sort of the newer kind of FIT fecal DNA or multi-targeted stool DNA tests, that sensitivity goes up to 90% or so. So it'll pick up about 9 out of 10 patients. So not perfect, but quite good. So obviously, this disease, colon cancer, is the perfect disease that's situated to be successful for screening because we have tests that can find disease at early stages and we can do something about it. But these tests that we're talking about have to be accessible to all of us, not just those in this room that are connected to GI and motivated, but our friends, our family members, our neighbors, our patients who really are just as susceptible to this disease as we are. We have a few challenges in this issue. As many of you know, 2021, all of our GI societies and cancer societies essentially expanded screening to include 45 to 49-year-olds. So from the inception of screening in the 90s, it has always been age 50 and up. And now since 2021, 2022, we've really been encouraging 45 to 49-year-olds to come to our doors to get screening. Well, according to the US Census, that's essentially a bolus of 21 million adults. Okay, so that's 21 million people in this country that are immediately eligible, not a gradual sort of trickling of folks that need to get tested, but folks that are eligible right now. When we think about our system here at the University of Colorado, that's 150,000 people in the UC health system that are just ages 45 to 49, right? And you all are the ones on the front lines doing the pre-calls and trying to get folks in and listening to their issues and getting in and wait times and such. That is an incredible amount of individuals that need to get screening. I work at the VA as well. And our VA system is also a resource restricted system. Right now, the entire VA system across the country does no more than 300,000 colonoscopies a year. That's just what the capacity that we have is. That's almost exactly the amount of 45 to 49-year-olds we have in the VA system. And so that brings us to 1.6 million people in the VA system who need colon cancer screening, and our colonoscopy capacity is only about 300,000. So you can see there's an immediate mismatch when we're talking about what tests these folks can actually have access to. So when we're thinking about, what is the best test, when we think about this for ourselves, our family members, our patients, and our society, it might seem obvious that, well, colonoscopy has the best sensitivity for cancer. That's the best test. But the issue is not everybody's getting it. Okay. So if you look at the cost and the adherence, we know that colonoscopy, some of these newer tests cost more. And although there's lots of efforts that have been successful at decreasing that cost, it's still time away from life, family, need to get a ride to get in for that procedure. And as a result of that, really the compliance with individuals who have been counseled to get a colonoscopy is only about 50 to 60%. And we see that in the drop-off rates, right? The schedule's full leading into an endoscopy block 2 days before it starts to peter off, and then day of, especially in these afternoon blocks, people fall off. And I see Deidre laughing because it's the bane of her existence at times. But when we think about, okay, if we have, this societal issue and these individuals who are out there who have colon cancer, wouldn't it be ideal to just make sure everybody got a colonoscopy? Then we'd pick up every single one of these people. But the problem is, if only 50 to 60% of people are actually getting their colonoscopies, well, guess what? That leaves us with, at random, up to half of people out there with colon cancer just not even getting any screening test. So the compliance with these stool-based tests maybe is a little bit better. They're easier to do. They're at home in the privacy of one's home. The multi-targeted stool DNA test only has to be done every 3 years. What if we just recommended that everybody get a FIT fecal DNA or a FIT test? Compliance is a little bit better, 70 to 90%. But again, because it's not 100%, we're still missing people that have cancer. So even with both of these strategies, there are people who are going undiagnosed with their colon cancer where it can progress to later stage disease. So that's part of the rationale for why our societies really encourage offering options, okay? A menu of options to find the best fit for a patient. And this is based on data. This was a study where over 12,000 individuals were basically randomized to three things: either just told to get a colonoscopy, or counseled to give a colonoscopy, and if they declined it, offered a FIT, or just given the option to do either. The adherence to screening was pretty bad across the board, and this is a study from Poland, but participation rate was only about 17-18% in those who were just told to get a colonoscopy. Although not ideal, the participation rate was quite a bit better in the individuals that were either offered sequential screening, meaning if you decline a colonoscopy, please at least do a FIT, or the menu of options. And so it really does emphasize that offering options improves compliance. And what we really care about, right, is how many people do we actually pick up who have the disease? Guess what? Across the board, even though the compliance rate was much higher for FIT fecal DNA, we're finding about the same amount of things. So I don't think anyone can argue that colonoscopy is theoretically the best test if it's not really even getting done. Our GI societies therefore really recommend a tiered approach, to offer tier 1 tests, colonoscopy if that's declined, then FIT. And if both of those tests are not preferred, then kind of to go down in the tiers of recommendations where you see CT colonography, multi-targeted stool DNA, and then, if available, potentially capsule. So what if we were to offer both, right? And just said, hey, try to just get the test that you can get done. And that's kind of what we're doing right now in the United States. There's many large healthcare systems like Kaiser where that's what they do. If a patient requests a colonoscopy, that's what they get. But if they decline it, they just get mailed a FIT test. And Kaiser has really outstanding screening rates for their entire encatchment population. That's in some ways what the VA is modeling as well, is that if the patients are not able to get a colonoscopy, at least a FIT reminder is sent and the patients get mailed a FIT test. But that's still leaving patients undiagnosed, because even with the combination of those things, not every American is getting screened. So how well are we doing nationwide? This is really actually data for just 50 to 75-year-olds. But if you look at Colorado, we're under 70% of eligible individuals 50 to 75 actually getting screened. And when you look nationwide, it's tightly correlated to age. And what's really kind of scary is that 50 to 54-year-olds, only about 50% of individuals are actually getting screened. That's not even to add our 45 to 49-year-olds who now really are eligible and should be getting screened. And when we add those folks, that actually brings our Colorado number overall down to about 60% adherence to screening. And when we break out those individuals across the country, only about 20% of 45 to 49-year-olds are getting colon cancer screening right now. So we have a long ways to go. So clearly, this issue needs a lot more work. How do we make this test widely available, affordable, accessible to every American out there? And of course, for those who want to and are motivated and have access to tests like colonoscopy, that's outstanding. But what about everybody else? For a long time, there was kind of this enthusiasm for blood tests, right? Because if you could do a blood test and just pair that with a regular doctor's visit, wouldn't that be so much easier for patients? Unfortunately, the blood test that was approved by the FDA in 2014 just didn't quite come to muster in terms of a test that would actually detect cancers at early stages. And I'll show you why. And so the blood test essentially relies on the tumor shedding cells into the circulating blood. And there would be, there's different assays that would pick up those circulating kind of tumor cells. And when we looked at how well these blood tests performed, not great. Overall sensitivity of picking up, on generation 1, 50% of colon cancers. And even for the kind of version 2 test, less than 70% of colon cancers. And what's really kind of concerning is that first few generations of blood tests did a very poor job of picking up early stage colon cancers. So if we're only picking up late stage cancers, that's really of no service as a screening test, because then patients are still met with all the morbidity and potential mortality of late stage disease. So based on this, really, the kind of Center for Medicare and Medicaid Services said, look, there's, kind of a lot of promise if we can make this work, but there's certain thresholds that have to be met before we're going to endorse a test. First of all, it has to be approved by the FDA. That, of course, makes complete sense. So they set a minimum sensitivity threshold of 74%, which to me, I think is still on the low side. And then a test specificity of over 90%. So of course, these older generation tests were far short of meeting that 74% sensitivity. But the really exciting thing is that really just as of a publication in the middle of March, we actually are seeing that there's probably going to be a lot more promise with emerging blood tests to detect cancer at those earlier stages where we want to. They take advantage of a lot of different things, and there's a bunch of different assays that are under development right now. But the one that was just published, I'll show you the data on. In addition to detecting kind of circulating tumor cells, it actually also adds kind of methylation markers, so kind of changes to the DNA, and then immune cells that have been shown to be associated with cancer. So it's not just the circulating free tumor DNA, but additional things that we think are likely the driver for improved sensitivity. So how do they compare? How does this blood test compare to our current existing tests? Well, I don't know if you guys saw some of these headlines just a couple weeks ago that were, this paper was published in the middle of March, but it's quite promising. So according to the data published in this paper a couple weeks ago, the sensitivity for this blood test to detect any cancer, and this study included over 20,000 Americans who were average risk for colon cancer, was 83%. Okay, so it'll pick up 8 out of 10 cancers. For those earlier stage cancers, stage 1, 2, and 3, the sensitivity was about 87.5%, so picking up 8 to 9 out of 10 cancers. So when we put it next to our existing tests, it actually has a comparable sensitivity to FIT testing, the stool-based test. But it's important to note that that blood test, again, is a cancer screening test. It's not designed to screen for or find precancerous polyps. The cost issue is one that we'll see sort of how it evolves, but current estimates suggest that it would be $800 to $900 or $1,000. But if approved by the FDA, and if it meets those criteria that I showed you from the Center for Medicare and Medicaid Services, then it would likely be considered under all these different guidelines for evidence review, and then be covered under the Affordable Care Act if it makes it through those steps. So it's still not ready for prime time by any measure, but it will be very soon. It's just in the process of getting FDA approval right now. And as we talked about, that could be another adjunct to the tools that we have in our toolbox. So if we add the sensitivity of this blood test, the adherence is potentially very promising. So people who can't come in for a colonoscopy, forget to submit their stool kit, maybe they would be able to come in for a blood test or get one when they get their thyroid checked or their cholesterol checked. So the adherence piece is quite promising. So then you can envision a scenario where for the folks that don't get fit or don't get colonoscopy, if we are able to introduce Shield, we might see a situation where we possibly could get screening out to every American and potentially detect these cancers at earlier stages and make a difference for our patients. The key is always, to offer our patients an option. And I think the message for all of us, whenever patients, family members, friends ask us what's the best test is the one that gets done. And maybe the best test for me or you is going to be different than the best test for our neighbor who, is really squeamish around colonoscopy. But I think reinforcing that screening works and screening can improve lives and that there are a menu of options is a really, really important message. And the best test is the one that someone's willing to get done. So I'll shift gears here and talk about polyp surveillance. And as we're chatting, I hope there's a lot of questions that are coming up. We'll answer them at the end. And also, if you're online, please feel free to enter those in real time, and we'll address those questions at the end as well. So polyp surveillance, right? This is kind of our bread and butter. What we do colonoscopy, we find polyps, and then we kind of get these patients into this cycle of surveillance, thinking that, gosh, patients who have polyps are at increased risk of cancer, and if we do colonoscopy more frequently, we can decrease their risk over time. As you all know, not all polyps are the same. We have, kind of two major categories of polyps that we think about: the adenomatous polyps, which include our tubular adenomas, the tubulovillous adenomas, the villous adenomas. These are the kind of very traditionally possible precancer polyps that we're looking for during screening colonoscopy. And then the serrated polyps. And these polyps, are a little bit more subtle, and they include multiple types of polyps. So, the hyperplastic polyps are the typical polyps in the left colon that we don't care that much about. Those are not precancerous. Whereas the sessile serrated polyps, or sessile serrated lesions, sessile serrated adenomas, all equivalent terms, those are potentially precancerous, as well as these traditional serrated adenomas. And so we know that the hyperplastic polyps are very, very common, but generally most folks that you scope with don't even touch them because they're not precancerous. On the other hand, tubular adenomas, sessile serrated polyps, are potentially precancerous. And then TVAs, villous adenomas, traditional serrated adenomas are potentially precancerous and considered slightly higher risk. And then, of course, you can have tubular adenomas that might have high-grade dysplasia, or sessile serrated polyps with any dysplasia, which then with those features are also considered in the slightly higher risk pool. And so these polyps, we can find them throughout the colon. Certainly the hyperplastic polyps are typically in the sigmoid colon, the rectum, and you see many of us just drive by them and not do anything about them. The sessile serrated lesions are typically in the right side of the colon, the ascending colon, the cecum, the transverse. The traditional serrated adenomas usually are in the rectum, and I actually don't have a good explanation as to why they're only found in the rectum. And then adenomas, of course, can be found throughout the colon. The terminology around polyps can be a little bit confusing, but in general, we kind of think about polyps as either, advanced or non-advanced, high risk or low risk. But exactly how to designate which polyps fit into those buckets can be a little confusing. So generally speaking, we think about non-advanced adenomas or non-advanced serrated lesions as being those polyps that are less than a centimeter in size, and just finding one or two of them. On the other hand, advanced adenomas or advanced serrated lesions are polyps that are greater than a centimeter in size. For the adenomas, they have villous architecture or high-grade dysplasia. And then for the advanced serrated lesions, they can have any dysplasia. And then sometimes you'll hear people use the term advanced colorectal neoplasia, which is basically just combining these advanced polyps with any cancer. So the only reason I go through this is because sometimes the studies sort of combine some of these things. So just to kind of know what types of polyps actually we're talking about. So over the last few years, what we are now starting to recognize is that small polyps are really low risk. So patients who have 1 to 2 small polyps, less than 10 millimeters in size, they actually have about the same risk of cancer or dying from cancer as those with no polyps. Okay? And so this is really kind of disruptive new information, because for many, many years, patients who had polyps, they would kind of get into this like cycle of surveillance. Oh, you've got an adenoma, come back in 5 years. More recently, and we've kind of extended the surveillance intervals, but there's emerging data that patients that have 1 to 2 of these small adenomas or cell-saturated polyps have the same risk of getting colon cancer as people with no polyps. And intuitively, right, for those in the room, that makes sense, right? We are finding more and more teeny tiny little polyps as our imaging techniques improve, as we have artificial intelligence that helps us find these little guys. Maybe polyps that 5 or 10 years ago we wouldn't have even seen with the old 180 scopes or, without AI. And so it's really not that surprising to know that they probably are not as high risk as we used to think. And there's been now multiple additional studies that confirm this, that the risk for those that have 1 to 2 small polyps is about the same as those with no polyps. What about the people that have 3 or more small polyps? Historically, we used to bring these patients back in 3 years because we thought, gosh, you have 3 or more, that's kind of considered a high risk finding. Again, as we're increasingly finding more and more of these polyps during colonoscopy, essentially what we're starting to recognize is, again, it may not confer as high risk as we thought. And so, there's now been studies that show that patients who have 3 to 4 or even greater than 3 as a bucket, small polyps, have about the same long-term risk of having another advanced lesion, either it's advanced polyp or cancer, as those with 1 to 2 small polyps. So even that bucket we're starting to recognize being less risk than we used to think. With that said, those with those bigger polyps, advanced lesions, right, 1 centimeter or greater, or any dysplasia, villus architecture, those are still high risk. And so we really do need to kind of parse those patients out and do more careful surveillance in those individuals. So based on that information, in 2020, the Multi-Society Task Force updated its guidelines on what to do for polyp surveillance. And really what they recommended is that individuals who have a normal colonoscopy or just hyperplastic polyps should be getting colonoscopy again in 10 years. That's not a big change. The change was that those with 1 to 2 adenomas less than 10 millimeters, they actually spaced it out to 7 to 10-year surveillance. And in fact, I sit on the Multi-Society Task Force, and the discussion in the group was like, the data actually supports 10 years, but we're just not quite ready to make that leap yet. So let's give our doctors, let's give our patients a little bit of wiggle room. But I suspect as more data comes out, it's going to get even more spaced out. Those with 1 to 2 small cell-saturated polyps, we recommend 5 to 10 years. And again, it's because we think it's about the same risk as having no polyps at all. But we have less data for the cell-saturated polyps compared to the adenomas. And so they said, let's leave it a range, but that range goes up to 10 years. For those with 3 to 4 small polyps, they actually relaxed that guideline from a kind of definitive 3 years to 3 to 5 years. And then we still do 3-year close surveillance for our patients who have those advanced polyps or more than 10 adenomas, where we bring them back in about a year. Overall, in our country, we're doing a lot of surveillance colonoscopy. We're doing too much surveillance colonoscopy, I would editorialize, but the data actually also shows that. So this is a study where they looked at kind of the indications for people getting colonoscopy, surveillance colonoscopy, and 26% of patients with no polyps were getting colonoscopy within 5 years, right? And we see this in our GI lab, where we kind of look and we say, oh, you just had a colonoscopy 4 years ago. Oh, well, that was at Kaiser, and my doctor just said maybe I should get another one. Okay, well, that's probably overutilization of colonoscopy. You might say, well, maybe it's because, we're in this sort of for-profit system and there's incentives to overdo it. Well, even within the VA system, we are doing too much colonoscopy. And you can see all the individuals that are highlighted yellow there are just getting colonoscopy too early. So with that, you can kind of think about the problems that causes, right? People are getting older, we're finding more and more polyps, and they're just in this cycle of surveillance that may not actually benefit them if they have the same risk of getting colon cancer as people that have no polyps. It clogs up capacity for those 45 to 49-year-olds that we need to get screened for the first time, or higher risk patients. And certainly as individuals get older, even though colonoscopy is overall a very safe, very well-tolerated test, it does increase risk as our patients age. And the data shows that 28 out of 1,000 older adults will have some type of adverse event with colonoscopy, whether it's bleeding, perforation, or some anesthesia-related event. So is there a better way? Are we just stuck in this gerbil wheel of surveillance? Well, I just want to tell you about two really exciting changes and studies that we're doing that may impact how we take care of our patients. So this is a study, the co-op study, that we are leading with Kaiser as well as Dartmouth, where essentially we are going to expand the study to 14 sites across the country where 65 to 82-year-olds, so our older adults who have a history of these low-risk polyps, whether it was 5 years ago, 7 years ago, when they are coming due for surveillance, typically, right? As maybe Dr. Patel of 2015 maybe recommended to a patient come back in 5 years, but now they're 80. They might have other medical issues. We will actually offer them a randomization to either surveillance colonoscopy, which would be standard of care, or a FIT test, that fecal immunochemical test, to really kind of get an objective risk stratification of like, well, could there really be something going on? And of course, if it's positive, we do a colonoscopy. And what we're aiming to look at is, at the end of the study period, is there a difference in who gets colon cancer or who dies from colon cancer between the FIT arm and the colonoscopy arm? And what is actually otherwise happening to our older adults? Are they dying from other causes? Are there other things, other issues that are going on? And we hypothesize, of course, that FIT is a safe option for surveillance in our older adults. And that's really disruptive, right? Because for a long time we said, no, FIT is just for screening. And so this could potentially change the paradigm of how we approach kind of more risk stratified surveillance. The other study that many of you may be familiar with, because we're kind of introducing this to a lot of our patients in endoscopy, is the Forte trial. And that's essentially taking anyone who comes through our doors for screening colonoscopy. If we find 1 to 2 small polyps, we're offering them participation where we randomize them to either 5-year surveillance or 10-year surveillance. And the goal is to really see, with a prospective randomized controlled trial, whether there's any difference in the rates of colon cancer and the deaths from colon cancer. And this is a multi-center study across the country where we aim to recruit almost 10,000 patients. So these studies will help us answer some of these questions. How can we be a little bit more sophisticated in polyp surveillance as we find more and more polyps in all these patients that we scope? And is 10 years okay to really space out for our patients that have 1 to 2 low-risk polyps? So if I'll just close before we field some questions and discussion, I think the best test is the test that gets done, and we have to take into account what the test is designed to detect and whether the patient's on board with that, and just how affordable and accessible it is to a patient. And honestly, low-risk polyps really are low risk, and they may actually be the same risk as those with no polyps. And so as we think about how we approach colonoscopy, it's really important to make sure we're using it thoughtfully and opening up capacity for individuals who would really benefit from it. So appreciate everyone's attention and excited to take any questions that you may have. Katie, yeah. Oh, that's a great question. So I'll repeat it for the Zoom audience. Katie Dickerman asked how AI will kind of be incorporated into polyp detection and cancer prevention. A few different ways, actually. And it's already here, as you well know. At the University of Colorado, we use the GI Genius artificial intelligence system, which is a polyp detection system. And what we know from the data is that it actually does improve polyp detection, particularly kind of small polyps, subtle polyps. And I think the promise, honestly, Katie, is that, we have a lot of outstanding docs that are high detectors. That's not necessarily the case in every practice across the country. there's a lot of variability in how well people detect polyps or how much time they spend detecting polyps. And so in some ways, the AI helps even that playing field because there's really kind of longstanding data that if you have more eyes looking at the screen, you improve polyp detection, right? So studies where nurses or techs in the room are also have their eyes trained on the screen, adenoma detection is better than if they don't. Or trainees involved in procedures, adenoma detection is better as opposed to a solo endoscopist. And so in some ways, AI just serves as that consistent, not looking away, grabbing a tool set of eyes. I think the other areas where it's going to be really powerful and impactful is in polyp characterization. So, it's not quite ready for prime time yet here in the United States, at least commercially, but we participated in a study a couple of years ago that will be published soon, looking at, doing real-time diagnosis of polyps while we do colonoscopy. So, right, I told you that these hyperplastic polyps are not precancerous. And many of us feel very comfortable looking at that polyp saying it's hyperplastic. I feel high confidence with that, just driving back and looking for the actual high-risk polyp and leaving it alone. But the polyp characterization system puts a little, bounding box over the polyp. You press a button and it gives you kind of a computerized prediction of polyp histology. And you, of course, weigh that with your clinical suspicion of the lesion. Of course, if you're not sure, you just take it out anyways. But that's another way that AI will become kind of a standard part of our care in colonoscopy and colon cancer prevention. And then not to go off on too much of a tangent, but AI is everywhere, and I think as AI algorithms are applied to our electronic health record, kind of upstream of our little world of colonoscopy, there's really exciting ways that the different AI platforms can essentially scrub an electronic health record and identify high-risk patients. So those who went to the ER and happened to have iron deficiency and never followed up or never had a outpatient doctor take a look at that, it can pick those up. Or people who had a diagnostic code for hematochezia because they went to urgent care and maybe it was just diagnosed as an outpatient and they didn't follow up. So I think there's some exciting applications there to kind of look at the bigger picture of, yes, we take care of the people in the highest quality way we can that make it through our doors, but how do we get more people through our doors?
Kaiser, for Kaiser. So I think we've noticed a problem with the fit test. One thing is patients will test until they test negative, and then they say, "Yeah, I don't need it anymore," right? And then the other issue we found is at the PCP where the tests are getting out to the patients, and sometimes it's not rolled out in the right way. The wrong people are getting the fit test, or say somebody who's definitely they're on surveillance. They're coming in every 3 years or 5 years, and then somehow we get these patients every so often. All of a sudden the PCP gave them a fit test. So then they're either coming in getting scoped too early, and it throws them off. So we missed that.
Yeah, it's a big challenge. It's a huge challenge. And Kaiser is kind of one of the aspirational examples of how to roll out a fit program. And if you all are telling us, that there's these issues, it's even more daunting for folks that are not in an encaptured healthcare system. But I think you bring up a really good point, right? A successful fit program requires such resource intensive navigation, right? Yeah. And at every step along the way. So education from the moment the patient walks through the door of what the fit test is actually designed to detect and which patient is best suited to the fit test, right? And so that's the drop off for the patient who just had a colonoscopy a few years ago, is in surveillance. Why are they getting a fit test? That should never have been given to them, right? And then, for the patients to have a partner, a navigator to explain look, it doesn't matter if it's positive now and not positive again. It really should, any abnormal test should be followed up with a colonoscopy because tumors can intermittently shed blood, and this can be something transient, but it is really resource intensive. And so it's not surprising that in the community, it's just not a test that's done very commonly. And to add on top of all of that, to have to do it every year, right? To go through this song and dance with primary care and patients every year, by the time you navigate somebody from fit to abnormal fit to colonoscopy, it's already been another year, and so that's in part why a lot of, health, I think primary care practices just say, I'm not doing that. But what we see from the GI side is that there's a colonoscopy order from 2019, 2020, 2021, 2022, and they're just open orders and patients just aren't coming. So we need an alternative. And, I'm really optimistic about these blood-based assays that they can overcome some of this multi-step problem, with FIT.
Yeah.
But some of it is we're going to run into the same growing pains, right? Who's the appropriate person to get the blood test in? Not somebody who just had a high quality colonoscopy last year. If it's abnormal, they still need to make their way to a colonoscopy suite. So some of those problems we might still see, but at least in terms of getting the sample submitted and, getting people to complete that first step, it might be a little
I
bit
even
easier.
joked around and, throughout the idea. It's like, okay, you do your fit test, you come back positive. Okay, then you come in, you have the colonoscopy done on your scheduled date. Don't cancel. We'll give you also, you do the prep, you do the whole procedure, and we'll give you a $25 gift card for the buffet. Right around like the time between Thanksgiving and Christmas, that's the highest rate of cancellations, right?
Yeah. Incentives, right? It's all about kind of tipping the incentives. You can go ahead and I can repeat it. It's a good question. So the question is, do we anticipate the screening age to even go lower than 45? So many of you who have heard me talk before have talked about this phenomenon of younger individuals getting cancer, and it's really scary. We're seeing increasing rates of young individuals getting cancer, and I think decreasing the screening age to 45 was a start, but only 80% of the cancers diagnosed in those under the age of 50 are between 45 and 49. Right, so we're still missing those younger. A kind of prominent example of Chadwick Boseman. He passed away of colon cancer, advanced stage colon cancer at 42 or 43. And so that's a really good question. I think it comes back to that, infographic map that I showed you. It would be ideal to decrease the screening age to the youngest possible to pick up 100% of cases. How feasible is that, to implement, across our diverse, our diverse country in a way that it doesn't necessarily kind of take away from other higher risk patients who need it? I think it's certainly possible that the age goes down, but my guess it will be in a tiered approach for a test that's much more accessible and can be implemented widely. And so there are some health systems where, like for instance in Taiwan, they offer FIT testing 40 plus, but they don't offer colonoscopy out of the gate unless there's higher risk features like family history or symptoms. And so, something like that, I think, may be around the corner, but I think before a big change, it would really require. There was already so much controversy in decreasing it to 45 because people are afraid of these issues. We'd have to really address, how we could actually practically implement that. Because, I don't want to go back 50 slides, but, there's another huge chunk of Americans that are, for instance, 40 to 45.
Hi. My question was going to be, is there anything being done to increase the adequacy of prep? Because I feel like a lot of the time we go in and it's not great. And sometimes we recognize it was the SU prep or whatever it might have been. Is there anything that's trying to be done to like increase what patients are getting?
Yeah, that's a really great question. And so much of the quality of the colonoscopy is dependent on the prep. It's probably a multi-layered issue. And so not necessarily touching in detail about, adherence to the prep or, some of the medical issues that ideally could be navigated ahead of time, like, diabetes or narcotic use or whatever that might require more aggressive prep. Just talking about the preps that are available, I think the challenge is that there are preps that will just not be sufficient for a certain subset of patients that we can't predict. And it might be because of chronic constipation. It might be because of, a variety of issues that even when we look at their medication list, even when we look at their medical problems, we wouldn't have predicted that they have issues. Or maybe it's prior pelvic surgery or something like that that's making it harder for a patient to prep. And that's always going to be a challenge. In comparing kind of the preps head to head, what we definitely know is that the lower volume preps have better adherence. And so, that out of the gate is something that can at least help patients complete what we prescribe. And that split dose prepping is the standard of care to provide additional flush on the back end. But the tough issue is that there's going to be people that have inadequate prep, and as much as we try to predict which ones might, it's not a perfect algorithm. Which kind of environment do you practice in? UC Health Highlands Ranch. So even that patient population is quite different than, for instance, what we see at UC Health, and certainly is very different than what we see at the VA. But I'll give you an example for the VA. It's an older patient population, more comorbid. We actually, as a standard, recommend 2-day bowel preps for almost everybody over a certain age group. And maybe we overshoot in a proportion of patients, but that has significantly improved our adequacy rates. So I think one of the things that for the Highlands Ranch group, if you guys are really struggling with the prep, working with kind of a quality team or a quality officer to go back and audit which ones are inadequate and try to understand where along that step of the process it is, whether it's the actual prep or patient's tolerability of it, or adherence to it, or whether there's some way that you can pluck those people out and say, gosh, in retrospect, this patient is on narcotics, or this patient does have diabetes. Maybe we should have a different approach for our diabetic patients, or whatever the subset of medical issues are. I think I went over time. So thank you so much, Lula, for inviting me to speak. It's always a treat to come to this conference, so I appreciate everyone's attention.
Thank you so much. That was absolutely amazing. We have one more lecture today. The faculty for our next lecture is one of our PAs that we work with. Our APPs in the lab are everything. They work extremely hard day in and day out to filter all of our urgent patients, do so many things that I don't even understand how they get done. We're very thankful for them. They're always in the trenches advocating for not only the patients and like our urgent patients and what they need, but also for us as a unit. So very thankful for our APPs. So without further ado, we have Caitlin Cookson, and she is going to talk about ERCP, which is our bread and butter.
Thank you so much, Lula. As she said, I'm Caitlin. I'm a PA, work primarily with the inpatient team for the GI Therapeutics Service. Last talk of the day, so we'll get out of here soon, okay? Doing great. So today I'm going to talk about indications for ERCP. I will also quickly cover what an ERCP is. Review patient selection criteria for ERCP, as well as common adverse events associated with ERCP, and then we'll really dig into the indications. So ERCP, it's an endoscopic retrograde cholangiopancreatography. It's an advanced endoscopic procedure that utilizes endoscopy as well as fluoroscopy to evaluate the biliary tree as well as the pancreatic duct. This procedure is intended to be a therapeutic procedure. We do not typically do this diagnostically. During the procedure, generally, we will utilize general anesthesia. Patients are typically proned, and a side viewing upper endoscope is guided into the second portion of the duodenum. The bile duct and the pancreatic duct are accessed via the ampulla of Vater. And cannulation of the duct is usually achieved with a guide wire under fluoroscopy, and then it's followed by either a biliary or pancreatic sphincterotomy. And then once we have achieved that, that's when we begin the therapeutic portion of the procedure. These are some endoscopic images that we see before, during, and after. So the image up here, I have a pointer, maybe? Yeah. So image here is the major papilla before cannulation. So that's what we looks like right when we get in. The central picture here is a picture while we're actually performing that biliary sphincterotomy and opening it up a little bit. And then the final picture is a picture of, that's a big gallstone there. And that's the picture of the papilla after the sphincterotomy and removal of the stone. So it can be a busy room. Setup's important. Typically we have the endoscopist, of course, and then 2 assistants, typically our fabulous nurses. Anesthesia staff will be in there. And then depending on your facility, you may have radiology technicians in there as well. So with the room, you'll have a C-arm, an anesthesia workspace, and then at least 2 screens for endoscopic viewing as well as fluoroscopy images. So it can be busy. It's important that it's set up for best workflow. Patient selection. The ASGE doesn't recommend any routine radiographic, cardiac, or laboratory testing for otherwise healthy patients. A lot of our ERCP patients aren't usually otherwise healthy patients, though. So we always want to keep that in mind. Pregnancy test for women of childbearing potential. People that are actively bleeding or with anemia, it's a good idea to get a CBC with the hemoglobin and hematocrit, and then blood typing. And then patients with biliary disease, active bleeding, or poor nutrition should have some coagulation studies. As I mentioned, general anesthesia is usually utilized for this, so patients need to be NPO for at least 8 hours. And then we want to be thinking about any other major cardiopulmonary conditions patients might have that may increase their anesthesia risk before recommending the procedure. And then for anticoagulation, it is considered a high-risk bleeding procedure. That biliary sphincterotomy and a highly vascularized duodenum is risky, so we need to be wary of chronic anticoagulation. Generally speaking, there's going to be caveats for all of these, but generally we like to hold DOACs for 24 to 48 hours, and then our antiplatelet agents need to be held around 5 to 7 days. Complications for ERCP, we see an overall complication rate running about 5 to 12%. This is one of the higher adverse event rates compared to other endoscopic procedures. The most common ones we see, post-ERCP pancreatitis runs about 3 to 10%. Our most common one that is reported with ERCP. These can range from mild and might be able to be managed as an outpatient, or they can be severe and life-threatening. They can be really serious. We do not routinely monitor lipase after these procedures, though. They really should only be obtained, and lipase should only be obtained in symptomatic patients. Bleeding we see about 1% of the time. That's typically related to that sphincterotomy. If there's a persistent bleed, patients may require a repeat procedure. Perforation about 1% of the time, and infection also about 1%. And the infection is usually related to incomplete drainage of the biliary tree or the pancreatic duct, and that would be considered a post-ERCP cholangitis. Okay, so jumping into the indications, I've split it up for us from a biliary perspective and a pancreatic perspective. On the biliary side, we have choledocholithiasis, that can be with or without acute cholangitis, drainage of malignant biliary complications, post-surgical complications, PSC, and choledochal cyst. And then on the pancreatic side, typically you're seeing this from complications of either acute or chronic pancreatitis, including a pancreatic duct leak, PD stone, or PD stricture. So choledocholithiasis, this is the presence of gallstones within the biliary tree. Gallstones can be composed of different materials. There's cholesterol stones. Those are lighter in color, formed from cholesterol. There's about 80%, that comprises about 80%. And then pigmented stones are made of bilirubin and calcium salts, and that accounts for about 20% of stones. Patients will typically present with right upper quadrant pain. They may or may not have jaundice. They may have nausea, vomiting, fevers, chills, or epigastric pain. LFTs will typically be elevated in a cholestatic pattern. There's a few options for imaging for choledochal lithiasis, including abdominal ultrasound. That's a little bit less sensitive, but sometimes we can see the stones in the duct. CT abdomen, preferably with IV contrast. You'll usually see biliary dilation. You may or may not actually see the stones, depending on what they're composed of on the CT. And then MRCP, which is a specialized MRI of the abdomen, is the most sensitive imaging for choledochal lithiasis. After ERCP, if patients have an intact gallbladder, we will usually refer them for cholecystectomy so they don't keep popping stones into their duct. And then when we see a stone, even if patients are asymptomatic, we always want to make sure that they undergo an ERCP for removal, because choledochal lithiasis can have some serious complications, including gallstone acute pancreatitis and acute cholangitis, which is characterized by abdominal pain, jaundice, fever, and that indicates an infection within the biliary tree. When we see this, these patients require IV antibiotics, fluid resuscitation, and an emergent ERCP. Here are some pictures. This guy over here, that's an MRCP, and that orange arrow is pointing to the stone. That's actually I'm sorry, I said ERCP, it's an MRCP. That's actually my mother-in-law's picture. She presented with belly pain and jaundice at the last RMIE. And I got her in here, I was like, that looks like a stone. So Dr. Atwell graciously removed that for her. And then I don't know this person, but this is the CT, and you can see the stones in the gallbladder here, and then stones in the duct here. Those are radiopaque stones. Again, you can't see all stones on CT, but these you can. And then there's, this is a beefy bile duct here, nice upstream dilation from those ducts. And then during the ERCP itself, we have the fluoroscopy image with that yellow arrow pointing to the stone. The stones look like white filling defects on fluoroscopy. And then there's the endoscopic image of the stone that's been swept out. And then I wanted to include one of what cholangitis looks like. That's all pus coming from the duct, so that would indicate cholangitis. Moving on to malignant biliary complications. Pancreatic cancer and hepatic metastases, these both exert external compression on the ducts. With patients with pancreatic cancer, they'll typically present with jaundice. They may or may not have abdominal pain. They may have pruritus, clay-colored stools, dark urine, weight loss, or nausea and vomiting. They will usually have a CT or an MRCP that shows a pancreatic mass with upstream biliary dilation. And like I said, that mass from the pancreas exerts external compression onto that duct, which is basically blocking it off and inhibiting drainage. Definitive treatment for pancreatic cancer includes surgical resection or a Whipple procedure, if depending on the disease state, or palliative chemotherapy. And then hepatic metastases, similar idea to pancreatic cancer is that there's this mass exerting external compression on the bile ducts. Imaging will show that mass and then upstream biliary dilation. And if the compression from the hepatic mets is too far into the intrahepatics, it might not actually be amenable to stenting. So it's definitely helpful to have cross-sectional imaging, either a CT or an MRCP for those patients before procedure. We also have cholangiocarcinoma. This is a primary cancer of the bile ducts. On CT or MRCP, typically you will see either a biliary stricture or there will be an obvious mass associated with the bile ducts and then upstream biliary dilation. These patients will have a similar presentation to pancreatic cancer, usually jaundiced. They may or may not have abdominal pain, pruritus, weight loss, nausea, vomiting. ERCP in these patients provides diagnosis with brushings and or biopsy, and it also provides relief of that biliary obstruction. And treatment for cholangiocarcinoma is resection if amenable and there's not too many distant metastases, or palliative chemotherapy as well. So for all of those malignant biliary complications, as well as some in the coming indications, we'll utilize biliary stents. We have a few different types. There's temporary stents. They can be plastic or metal. The plastic stents can be utilized in the bile duct or the pancreatic duct. They come in a variety of length and diameters and kind of firmness. And you can see here, like there's double pigtail, there's all different kinds, depending on what you're treating. And then there is the covered self-expanding metal stent. This one, the metal stents only are utilized in the biliary tree. The covered metal stent can remain in place a little bit longer, up to 6-ish months. But you do want to use caution using these stents in patients with an intact gallbladder. There's a risk of caging off the cystic duct and precipitating an acute cholecystitis. And then we have permanent stents. This is an uncovered self-expanding metal stent. These are only placed in the setting of known biopsy-proven malignancies. And here's some pictures of our malignant biliary complications. On the far left over here, we have a CT, and you can see there's a mass here in the pancreas, and the bile duct upstream is dilated, and there's a distended gallbladder as well. The central picture is a fluoro image of a very, very tight malignant biliary stricture. You can see the duct below is kind of wide and above, and then we're missing it here from the stricture. And then I think this is a covered metal stent. It's either covered or an uncovered, but I think it's covered. And you can see this is what it looks like when it's coming out of the papilla. All right, onto our surgical complications. First, bile leak. We frequently see this in patients after a subtotal cholecystectomy because they can't surgically close the cystic duct during that procedure. But we can also see bile leaks associated with trauma or hepatectomies, partial hepatectomies. Usually there's not a lot of imaging associated with this diagnosis, but patients will have a JP drain placed after surgery, and they'll have a very high volume output of bilious drainage from that. Sometimes we can see 500 cc's to a liter a day. And then we'll place a stent for these. Usually we'll place a plastic one, occasionally covered metal stents, and they're left in place for 6 to 8 weeks. This does require a repeat ERCP. Patients will come back, we'll remove the stent, and then shoot a confirmation cholangiogram to make sure there's no ongoing leak. And the arrow here is pointing to this. This is the leak off a cystic duct after a subtotal chole, and the bile is just kind of leaking out into the abdominal cavity. Biliary strictures can also occur from surgery. We can see this in post-surgical stricture from clip placement or narrowing of bile ducts from scarring down after partial hepatectomies. We can also see anastomotic strictures in patients that have undergone Whipple's or liver transplants. Usually imaging will consist of a CT, ultrasound, or MRCP, and there will be dilated upstream bile ducts, and you can occasionally see a focal stricture as well. And this is managed with biliary stenting with or without dilation, usually with dilation. And this is a cholangiogram with a stricture, and you can actually see the clips right there that probably led to that. Those are cholecystectomy clips. All right. PSC, or primary sclerosing cholangitis, another indication for ERCP. This is a progressive disorder characterized by inflammation, fibrosis, scarring of the intrahepatic and or extrahepatic biliary tree. Often we see this in patients with IBD. It predisposes our patients to cholangiocarcinoma, that malignant bile duct. Preferred modality for diagnosis is MRCP. There's a few instances where patients will need to go to ERCP for diagnosis. And MRCP, as well as the cholangiogram, will show ducts that have a beaded appearance. It looks like little beads on a string. Patients will present with fatigue, pruritus, or right upper quadrant abdominal pain. ERCP is performed in patients with dominant duct strictures. Two purposes for this. One is to provide treatment with dilation, and the second is to either brush or biopsy to screen for cholangiocarcinoma. We don't typically stent patients with PSC. There's not a lot of data that they actually have improved outcomes, so usually it just involves dilation during the ERCP. And these patients are at increased risk for post-ERCP cholangitis as they have those beaded ducts. They don't get as good drainage of the dye that we use, so they are treated with prophylactic antibiotics. All right, on to pancreatic indications. Pancreatic duct stricture. These strictures can be caused by chronic pancreatitis, recurrent acute pancreatitis, trauma, surgical complication, pseudocyst, or malignancy. These patients will typically present with recurrent abdominal pain, symptoms of chronic pancreatitis. They may or may not have exocrine insufficiency. CT abdomen or MRCP will demonstrate a dilated PD with this stricture. Medical management is always an option. This includes abstinence from alcohol, adherence to a low-fat diet, small frequent meals, and pancreatic enzymes. Endoscopic therapy includes an ERCP with a pancreatic sphincterotomy, dilation, and stent placement. We really only typically stent patients that are symptomatic. Sometimes these can be found incidentally and they may not actually need ERCP, as well as patients that are maintaining sobriety. For refractory symptomatic strictures, they may require surgical management. So this is a nice pancreatogram that shows the stricture and then endoscopic view of a pancreatic duct stent. And pancreatic duct leak can result from acute or chronic pancreatitis, a traumatic injury, or surgical trauma. Patients will usually present with abdominal pain. They may or may not have ascites. They can develop pancreatic ascites. If they do, the fluid from the paracentesis will have an elevated lipase as well as an amylase of greater than 1,000 typically. We manage these both medically and endoscopically. Medical management includes NJ feeds or TPN for gut rest, as well as octreotide. Endoscopic treatment includes pancreatic duct stenting, typically with plastic stents. And then stenting allows for redirection of the pancreatic juices from going out into the peritoneal cavity, redirecting it back into the intestines. Whenever we're stenting anything in the pancreas, it will require at least 2 ERCPs because we'll have to go back in and remove the stent and confirm that the PD leak has resolved. And if the leak is refractory or not amenable to endoscopic management, it may require surgical referral for a distal pancreatectomy. And pancreatic duct stones, these are a result of chronic pancreatitis. Patients usually will present with abdominal pain, nausea, vomiting. Sometimes these are found incidentally as well, and we really only intervene on the symptomatic patients. These PD stones are composed of hardened digestive juices, and they're typically made up of pieces of calcium carbonate. For stones that are less than 10 millimeters, we can usually retrieve with ERCP with pancreatic sphincterotomy and then balloon or basket retrieval. When they're larger than 10 millimeters, they can be more difficult to remove and usually need to be broken up first. There's two ways we can go about this. The first one is per oral pancreatoscopy or POP. And this is a guided intracorporeal lithotripsy, and it utilizes EHL as well as laser lithotripsy to break those stones up into smaller fragments and then sweep them out. There's also extracorporeal shockwave lithotripsy or SVOL, which is similar to what people do for kidney stones, where there's a targeted shockwave to break up the stone, and then this is followed by ERCP. Some centers do same day, some centers do it after a couple weeks. And again, patients may fail endoscopic therapy, and if they're very symptomatic, they may require surgical referral as well. Here's some pictures of PD stones. So we have a CT scan that shows that bright calcification there is the pancreatic duct stone. And then you can see the pancreatic duct dilated upstream from that. And then this is an endoscopic view of what the stones actually look like once we sweep them out. And lastly, choledochal cyst. This isn't a strict indication for ERCP, but you might see people come through for this. These are congenital or acquired anomalies affecting the biliary tree. Patients may present with jaundice, abdominal pain, a palpable mass, or this may just be an incidental finding that's found on CT or even during an ERCP for another reason. They do cause biliary dilation. They can affect the extrahepatic or intrahepatic segment, and depending on what they affect, they get classified differently. All of these cysts, though, have a high risk for malignant transformation. So usually when they're found, these patients are just managed by surgery. but ERCP may be indicated as part of the preoperative workup. So occasionally we will do ERCPs for these. So in conclusion, ERCP, it's an advanced endoscopic procedure. It requires general anesthesia. It has a complication rate of 5 to 12%, which is higher on the higher end for our endoscopic procedures. So while it's still an overall safe and well-tolerated procedure, we really want to be thoughtful about who we're recommending receive an ERCP and make sure that they have a true indication to undergo the procedure. And this is my little dude and my big dude. Questions?
I was wondering, when you were talking about post ERCP pancreatitis, you were talking about lipase levels, and how we draw them. I was just wondering, like, how quickly that would show up on labs, and like how elevated does it get? Like, hours.
Yeah, you can
minutes?
see it. You can see it pretty quickly, within a few hours. We classify it as post-ERCP pancreatitis for symptoms that are onset within 24 hours. So really, that's the window where we see it, if they're going to develop post-ERCP pancreatitis. And then to diagnose pancreatitis, patients have to have lipase greater than 3 times upper limit of normal. They also have to have pain, which they should be having if we're drawing a lipase on them, right? Or radiographic imaging. So they have to have 2 of those 3 things. So we would want to see at least 3 times upper limits of normal. And the reason we don't routinely draw lipase is ERCP can increase lipase levels, and it isn't always indicative of a true post-ERCP pancreatitis, which is why we don't routinely draw that. So we really want it to be in conjunction with symptoms, so we know that we're really looking at a true pancreatitis.
Thank you.
All right. Well, thank you.
It was a great presentation. It's crazy how I can do stuff every single day. And then like your presentation and the EOS presentation earlier, I was like, oh, I didn't know that. I didn't know that. I didn't know that. So thank you so much. Okay, just a few things before we wrap up for the day. It looks like we're going to finish a little bit early. If you are staying at the Hyatt and you took a shuttle here, unfortunately, the shuttle is not going to be here for pickup until 5 p.m. It is a bit of a jaunt over there, and you do have to go across Colfax. So if you want to return, unfortunately, you'll have to hitch a ride or catch an Uber. And then I had a few people ask me about syllabus slides and recordings of today's course. Everybody that signed up should have gotten an email this morning with the syllabus and the slides from the presentations today. As far as the recording of the course today, that will be available in a couple weeks. We just have to get it all ready and everything, but you will have access to it at some point. Do we have any questions or closing remarks from anybody? All right, well, I think we're going to go ahead and adjourn for today. Thank you all for coming. It truly takes a village to put together this nursing course, and it's been an honor having you all here today.